Welcome and thanks for joining us. We'll be starting soon with our speakers. I just have a couple things to announce as everyone gets logged in. So first, you'll notice that this session does allow you to have your cameras and your mics on, but we ask that you follow our presenter's lead for when to do so. Next, if you'd like to ask a question during this session, please make sure and use the Q&A area to the right of the viewing window. And it looks like we do have a few folks in here, and there's going to be more arriving. So I'm going to go ahead and turn it over to our speakers, Karen Pearl and David B. Waters.
Thank you.
Great. Thank you, Mary.
So glad to be joining you all today. I hope you're all enjoying the conference so far. I am Karen Pearl, the President and CEO at God's Love We Deliver. We're based in New York, and we're here to talk to you today about scaling access to medically tailored home delivered meals through the Food is Medicine Coalition Accelerator. But before we do that, David, you want to introduce yourself?
Sure. It's nice to meet you all. Thank you. I hope we'll be able to connect individually. I'm David Waters. I'm the CEO of Community Servings and a longtime partner and colleague with Karen, God's Love We Deliver, as well as the Food is Medicine Coalition. So we're excited today to share with you our relatively new Food is Medicine Coalition Accelerator program.
Okay. So we're both going to go a little back and forth to share with you how we get to the accelerator, and then to tell you a little bit about the accelerator. Hopefully the people who have joined this are potential candidates for it. So we look forward to that. So next one, please, David. So we're going to start with a bold vision that all of us at the Food is Medicine Coalition have been working toward. And this is our belief that we are never going to achieve the healthcare goals of this country, which are improving outcomes, lowering costs, and creating equitable access, without fully integrating the medically tailored meal intervention into healthcare. And what's really important about this is that it is really setting out a big project that has a lot of different components to it. So if you can go to the next one, David. So this is the Food is Medicine Coalition and what our purposes are. The most important thing is that we are an association of nonprofits who have all been doing medically tailored food and nutrition services. And we really have 4 reasons for being, which all go to that vision. And the first is to complete the evidence-based medical food and nutrition intervention for those who are living with critical and chronic illness. The second is to advance public policy, because obviously integration into healthcare is not just a wish, it has a policy implication that we are working very hard to make happen. But we can't just wish it to be so without having research that substantiates why it is that we believe that medically tailored meal intervention meets those goals, lowers costs, increases outcomes, and it promotes equity. So we have a lot of research to share with you, and then ultimately best practices. And that's where the accelerator is part of our plan. In pulling together best practices, we're able to then teach other programs how to become medically tailored meal providers, helping us reach other goals, which is having access to medically tailored meals available to people separate from where they live, but access more fully. Next, please. So this is a map currently of where we are. The teal colored teardrops are the medically tailored meal providers that are already accredited by the Food is Medicine Coalition. We are adding to our community of providers 2 cohorts thus far from the accelerator. The first graduated in June, and they are that green teardrop. There are 4 programs in the first class, and we've already expanded to 5 programs in the second class. And that is that kind of, mustardy color teardrop. So you can start to see already, and we'll talk about this in a little while, how we're trying to fill in the country. The original providers, the teal, tend to be isolated in big cities, not much in the middle of the country, and we're starting to fill that in as well as in the South. So we're feeling pretty excited about this map and look forward to it continuing to grow in terms of providers. Next, please. And then that's how we got to the accelerator. So the accelerator was really, really designed to be a program that we could replicate and then scale to get more medically tailored meal providers working nationally. And we do that because we're able to leverage the expertise that we have as providers in all the different pieces that we see as essential to having a quality program. And that, of course, is operations, because we have to be able to feed people, but also policy and advocacy, and then the business and financial planning that goes into running an MTM program. And because those are our goals and the landscape that we cover, we have 4 very, very strong partners who are all working together. Community Servings and God's Love We Deliver are the 2 providing agencies. But then we're working with the Center for Health Law and Policy Innovation at Harvard Law School around policy and advocacy questions, and with the Nonprofit Finance Fund around business and financial planning to ensure the programs that are developing the MTM intervention have a way to sustain that, to ensure that they can actually not only launch it, but keep it growing to meet the needs in their communities. David, I think the next is yours.
That's right. Thanks, Karen. So let's take a step back. Probably many of you are already familiar with the concept of medically tailored meals, but just to sort of for a refresher, programs like ours originally grew up out of the HIV community 30, 35 years ago, when the majority of people with HIV were actually dying of malnutrition. It's what's called AIDS wasting syndrome. And programs grew up in major urban areas on the map that Karen was discussing to feed people with AIDS. And the 2 things that we learned early on was that sick people have no appetite. So if you want to get them to eat, you really have to bring them beautiful food. So across the coalition, we've committed to scratch-made food in significant volume. New York, God's Love, is much bigger than Boston, but in Boston, we're doing about 18,000 meals a week delivered to people's homes, to give you an idea. And the second thing we learned was that different people need different kinds of food based on what their illness is. So that's really where the idea of medically tailored meals came from. Probably many of you are providing meals in your community or running pantries, veggie prescription programs, et cetera. All of those are often incredibly important, but also perhaps feeding a bigger population than the medically tailored meal group, because we're looking at a much more targeted, very, very sick and isolated population. And part of the accelerator is, and our focus today is to sell you on why you might consider adding a MTM program to your suite of services and receiving coaching from us. So to give you an idea of how medically tailored meals work with our clients in the community, the clients typically are referred to us by a medical professional like their doctor or care manager with their health plan. And they're going to tell us what their patient's illness is, probably what their diagnosis is, what their medications are, what their lab scores are. So we're getting health information, which is more than a traditional anti-hunger program would get. We have to make sure we keep that all safe in a HIPAA appropriate environment. And from there, our dietitians, our RDNs, are going to do nutrition assessments to essentially prescribe a diet. And I'll talk more about the diets in a second. But they're going to prescribe a diet, and from there, our kitchen goes to work and begins preparing meals. Typically, we're they're different models, but typically we're delivering once a week or twice a week to a patient's home. And we're bringing them anywhere from 10 meals a week to 21 meals a week, depending on the program and the intervention. So lunch, dinner, and a snack in the case of Boston. Philly does 21 meals. And they're ready to go in their microwave. They're typically chilled and flash frozen. What's particularly exciting about the program, I think, is that we've also made the kind of holistic commitment to feed people who are sick, but also to recognize that if we bring one meal into a household, perhaps with a sick parent, they're going to give that first meal to their child or their children. So if we want to have the nutrient impact on the patient, we have to take the holistic viewpoint of feeding the whole family. Now, that could be feeding their children, feeding a caregiver, or it could be an elderly couple that would split that entree rather than have one eat and not the other. So again, feeding the whole family is tremendously important to us. So the meals arrive at your home in one of our refrigerated vans. The clients can enjoy the meals on their own schedule. They're microwavable, generally speaking. And they could be receiving the meals for typically 3 to 6 months, but some patients we have here in Boston have been on for 10 years, depending on their healthcare issues. And then they're going to see significant improvements in their health status, as we'll show you in our research portion, in as few as 12 weeks, which for a healthcare organization is tremendously exciting because food is usually thought of as more of an upstream intervention that might impact someone's life over years. But in the MTM intervention, we've been able to document clinical outcomes and cost savings in only 12 weeks. So on the left is how Community Servings in Boston thinks about medical diets. And on the right is God's Love's similar model, Karen's agency's model. On our side, we offer 15 different diets, which you can see arrayed around the circle. But what's unique is not that we provide 15 diets, but that we can multi-layer them. And that's really the distinguisher for a medically tailored meal provider. Some of you may already be providing, for instance, a diabetic diet or a DASH diet or cardiac diet. But in the medically tailored meal intervention, it's about patients with multiple comorbidities or multiple dietary restrictions. And the ability you can see there in the middle where we might leverage our diets to provide somebody with renal soft or diabetic mild, no fish. And in New York's example, they also do soft, minced, pureed, so different texture modifications that we don't do in Boston. We do a soft diet, but we don't go beyond that. So different programs have slightly different interpretations of this, slightly different number of diets. We're starting to add pediatric diets and diets specifically for high-risk pregnancies, maternal health issues, that sort of thing. But the way I describe it to people is my best friend had type 2 diabetes that was out of control, that led to kidney failure, dialysis, blindness, inability to walk, strokes, heart attacks, etc. He needed a diet that controlled for glucose, potassium, phosphorus, vitamin K, and sodium. And yet probably none of us, other than the RDNs, could run to the store tonight and prepare that meal. So we set people up to fail because they can't manage these complex diets on their own. And that's why the MTM intervention is so important. So that's a good segue into the research. The Foodist Medicine Coalition that Karen chairs and all of our programs sit amongst has a library of probably 200 research studies related to the health impacts of meals and food. So I'm just going to share with you some of the headlines, but if you've seen research around MTM, you might have seen the study that Community Servings published first in Health Affairs and then a larger study in the Journal of the American Medical Association. Those were done in partnership with the University of North Carolina School of Medicine, Dr. Seth Berkowitz, and Massachusetts General Hospital. And in those studies, they were specifically ROI studies, so looking at the cost savings of providing meals. And what we did was we looked retrospectively at people we had already fed, and through crazy circumstances, we were able to get access to their health billing records, partnering with the state Department of Public Health, and look at what happened when they were on our program. And what we saw was, net of the cost of food, a 16% reduction in their monthly healthcare costs. Now, patients typically on an MTM program are what are called high-cost, high-need patients. They're the most expensive with the most number of complex medical issues. So 16% is a big number and very attractive to healthcare. Similarly, or specifically, it was a 72% drop in admissions to skilled nursing facilities, 49% drop in hospitalizations, less ambulance usage, less visits to the emergency room, all very expensive services, and all attention grabbing to the healthcare world. So armed with the research, programs like God's Love and Community Servings have been able to get health insurance contracts to feed our sickest patients. So almost half of Community Servings patients are now fed through their health insurance. So for those of you who are in the larger anti-hunger world, it's exciting to see a portion of the hungry population in America being fed through a source other than government entitlement programs and philanthropy, because we all know there aren't enough resources to do our work. So the medically tailored meal program is particularly exciting in the context of all of our shared passion around anti-hunger. Karen.
Thank you, David. So I'm going to fill in that next bucket, which is the work that we do on policy. And that is really because we are such firm believers in the medically tailored meal program and intervention for people who are, as we like to say, the sickest of the sick. Or sometimes you've heard the statistic, the 50% of the population, the 5% of the population that takes up 50% of all spending in healthcare. So that's who we're targeting, and we're really trying to help bend that cost curve, as well as help people have far better outcomes, help them heal, help them get better, help them get stronger, help them live longer. And so our advocacy goal is to ensure that anyone in the United States in need of the medically tailored meal interventions has access to it, regardless of their ability to pay and regardless of where they live, which is why closing that map is important, hence the scaling of this into new geographies, but also why getting the policy change so that this is available to people who are using Medicaid, Medicare, and even private insurance to help pay for their medical needs. And then for people, and this is a little bit more into the hunger world, who are at risk or in early stages of nutrition-sensitive disease, to ensure that they have access to the tailored health promoting food that we offer through other food as medicine interventions. That was just a question in the Q&A, and if anybody else has questions, feel free to drop them in the Q&A and we'll do our best to get them answered live. But many of the people in the Food as Medicine Coalition are working more on things like grocery bags and other kinds of tailored interventions that will help people also heal and do better, and hopefully not get into the sickest of the sick category. Although there will always be people who are there, unfortunately, because of that's what happens with illness. So we work really hard on that. And we want to just tell you about one opportunity that's very alive right now. David, would you go to the next? Thank you. Which is a bill that has been introduced into the House. It is HR 5370. And HR 5370 is to promote the Medically Tailored Home Delivered Meals Demonstration Pilot Act of 2021. That is a mouthful, but we call it the MTM pilot, because it's just easier. And the demonstration, if it eventually gets passed in this House, in this session of Congress, will have at least 10 programs in 10 states that are working on the MTM intervention with Medicare beneficiaries. And we can talk about why Medicare in a moment, but let me just move on for a moment. For a minimum of a 12-week intervention, for a minimum of 2 meals per day, and then this will all be analyzed in terms of the effects, the positive effects in terms of health outcomes. So you'll see the list of eligible diagnoses there: congestive heart failure, diabetes, COPD. I won't keep reading, but you can see them all there. And if you're interested in supporting this, we are having a MTM Action Day on November 16th. It's a Tuesday coming up pretty fast. And if you'd like to learn more about it and/or sign up to participate, feel free to sign up for the Food is Medicine Coalition, which is FIM, Food is Medicine, fimcoalition.org. Hopefully that will be easy to remember, and then you'll get notices and we'll tell you what to do. So we're very excited about that, and we do hope that you will join us in promoting this pilot, because ultimately, when the pilot does prove successful, as we believe it will, this could truly change the course for the elderly and disabled in this country, making it possible for them to get medically tailored meals when they are dealing with severe and chronic illness. David, I think you take it back now to start the discussion on the accelerator.
That's great. So if we go back to the map that Karen was illustrating earlier, obviously 13 established medically tailored meal providers are not going to be able to answer that advocacy call for access to meals anywhere in the country. So we need to recruit and develop over time more mature medically tailored meal providers. And that's where the accelerator comes in. I jokingly refer to it as the MTM University. It's taking established nonprofit food programs who have a kitchen and are currently preparing meals and are ready to commit both to scratch cooking, but also to the complexity of medical diets, multi-layering of medical diets, and to, unlike traditional pantry programs, there's much more one-on-one work with the patient. There's data to be tracked. There's nutrition counseling and education for that patient. There's billing records, HIPAA concerns. But what's exciting about it as the opportunity is the potential to get reimbursed for the full cost of this through health insurance contracts, as both New York and Boston have proven, and many of our colleagues. So the way the accelerator is set up is it's a 12-month curriculum born, believe it or not, in the midst of the pandemic, which is pretty crazy. And it's sharing all the learnings of the Food is Medicine Coalition, and very specifically the learnings of Karen's team in New York and Boston's team here, in all the nitty-gritty of how you run a medically tailored meal program. So everything from how do you work with a client, how do you layer your diets, how do you do your purchasing, how do you manage your fleet of trucks, and what's particularly unique about it is it also brings in the expertise of the Center for Health Law at Harvard Law School and the Nonprofit Finance Fund. So at Harvard, it's called CHILPI is the acronym. CHILPI works directly with the members, the food programs in the cohort, to look at what the insurance regulations are in their state. So they and their law school students research the regulations and say, here are the best opportunities for you in the state of Oklahoma, say. And we help you develop the marketing tools to go out and pursue those contracts. And then the Nonprofit Finance Fund works with you to develop the business plan, because ultimately, if you're going to add a program like this, you need a well thought out plan for yourself and your management team, but also for your board and your funders to know that you can pull it off. So NFF is there to work with you to really look at your all-in cost, because ultimately you're going to have to quote a price for the intervention to your potential insurer contracts. So there's 12 months of online classes plus 2 3-day visits, one in Boston and one in New York. So you see the work happening, you meet your peers from around the country, and you get to a really great understanding of it. There are monthly office hours. And what we need in return is multiple staff members participating every month. So it's not the kind of thing where one person could be taking the message back, because it's such a diverse array of curricula. So you need to have the RDN listening in. You need to have your food service culinary person. There are times when you need your CFO involved, your policy people, et cetera. And then when you graduate, we're expecting that you will be ready to launch an MTM program within the next 6 months and join our coalition. Which is incredibly useful for your program, but incredibly important for us to have a bigger coalition and know that collectively we can cover more of the country. I think I have this one. I touched on this a little bit before, but so in the accelerator, we only work with nonprofit food programs who have a kitchen. And they have to have the capacity to undertake the 12-month program to bring staff to New York and Boston, be regular attendees, but also have the institutional capacity to actually mount an MTM program, because this isn't going to work if you're providing 20 or 30 meals or even feeding 30 or 40 people. You have to have the capacity to grow beyond that to really take on insurance contracts. The tuition for the program is $20,000. The cost is significantly higher than that, but it's covered by our grants. So it's $20,000 to the agency, paid out in several payments. The organization has to already have experience with food safety and commercial food production and have access to a licensed commercial kitchen. It would probably not work if you were subcontracting your meals out to a for-profit business. You would need to have your own kitchen. You would need, at least during the program, to have hired an RDN within 9 months of the program's inception, because a lot of what we're teaching you is specifically how to do the complex diets, and that requires an RDN to fully embrace that, to implement it in your kitchen, but also to counsel the clients and do the nutrition assessments. And then overall, we're looking for, which is I think the most exciting part, is like-minded souls and programs to make a commitment to both medically tailored and scratch-made meals for the people in your community who are experiencing illness. We know that this population is very scared, very isolated, often very hungry, and completely overwhelmed and feeling somewhat forgotten. So when our drivers knock on a door to bring them medically tailored meals, it is really a message from the community that says, you're not forgotten, we see you, and you deserve of this kind of high quality service. Karen.
Thanks, David. So as David said, this is a really rigorous program, and we've learned a lot even through the first year. But one of the things that we did, and then we've even strengthened in the second year, is to be sure that there are deliverables that programs have to work on. So they're not just showing up and listening or participating in discussion, but they're actually moving their program down the road to being able to launch their MTM intervention at the end of the 12 months. So there are deliverables in a variety of areas. There are deliverables that help them plan, and there are deliverables that help them then execute. And so here's the full list. I won't read them all to you, but I will point out a few. We do end up with each program having developed a business plan that not only is what they're doing when they launch, but also is about growth and sustainability. And that's really, really important, because that is the document, as David just said, that I think a lot of boards want to see as programs add another piece of business to what they know. So if I don't know who you're representing in terms of who's on the call, but if you're a food bank, for instance, and you've always done meals that people just pick up, or that during COVID you learned how to deliver them, now you're doing medically tailored meals, people want to know that you can sustain all of this change. But we also do things that are very practical, like we make some recipes available as examples. There are usually 5 or 6 from God's Love and 5 or 6 from Community Servings. That's a great start, but that's whatever, 10 or 12 examples. And people need a full menu that runs over a whole month and then repeats, or runs even longer than that. So they have to start developing menus. They have to start doing the nutrition analysis, because every one of the programs has to follow the Food is Medicine Coalition guidelines for what goes into a medically tailored meal for each kind of illness. So they have to show that they have mastered that they know what it means, what they're going to put into their menus. And then we have documents in there, as David was saying earlier, that part of sustainability is being able to convince the healthcare providers in your community that this is a worthwhile and important investment. And so they work on a scope that they would then put into their contracting. When they get to contracting, they work with Chilpy around what are the best ways to get those contracts, like are there more Medicaid or Medicare opportunities in their community? If they're lucky enough to have multiple providers, who might be the most open because they have contracted, let's say, with New York, with God's Love We Deliver, and maybe they'll do it in their community as well. So there's a lot of work that goes into choosing that. And then ultimately, we have them work on a pitch deck where they're able to pull together everything that they've learned around policy and advocacy and around the actual medically tailored meal intervention to use in the meetings with different contracting agencies, so that they can move from, it would be great if you would contract, to actually getting a successful contract executed and signed, so that they know that they have a certain amount of income that will be coming in and a certain level of work that they will actually be doing. And a lot of programs are doing all of that. Contracting takes a long time. And some programs have even decided to do this on a philanthropic basis, just as a pilot, to be able to demonstrate to potential health plans or hospitals that they actually can do it, that they can tailor the meals, they can get them delivered, they can have happy customers, and they can have good outcomes. So we work with plans to figure out where they want to go on their path to becoming an MTM provider, but we really want to be sure that they are equipped with all of the different pieces to be able to do the actual program, to get contracts, and then to be able to sustain it and to grow it. Next, please. So as I said, we learned a lot after the first lesson that we are trying to incorporate into any kind of recruitment for new programs, because the programs start every July 1st. And one is that if you want to join the accelerator and be a cohort participant, you need to have at least 3 individuals who regularly participate. And we actually go a little further in saying who they are. Like, you have to have somebody in the executive or the C-suite of your organization to ensure that there is that kind of commitment, whether that's a chief program person, whether that is an ops person. Many programs bring their CEO because it's so important as they go into a whole new line of business. But it has to be at least 3 people. You have to commit to attending our regularly scheduled meetings. We have webinars, we have office hours every month. And then we have, as David said, those 3 days in each of the 2 cities. And then you have to recognize that launching, it seems so simple, particularly if you're already doing meals, that doing MTM just isn't that complicated, and it is complicated. And so we really want people to understand that it takes time, and that what the first year cohorts told us is that they weren't all ready to launch at the end of June. Many have launched already. A couple is still working on it. Like, it is really changes your program. And so there's a lot that they have to think about and a lot that they have to put in place. And then it is particularly complicated if you are wanting to produce meals at a large scale. Ramping up at each program is really bigger. But I'm going to add one that's not on that slide, because I think in some ways it's been the hardest hurdle, which is the mind shift that goes from being solidly in the hunger world to actually moving into the medical world. Still, obviously, for people who are hungry, because they wouldn't need medically tailored meals home delivered to them if they weren't hungry. They have other means of taking care of themselves. So it's not like you're going from hunger to no hunger, but you're really moving from the hunger world, which is focused on reaching a lot of people, often with the very same thing, to a medical model, which is tailoring the treatment or the intervention for the individual and their specific circumstances, which is why you saw those wheels from Community Servings and God's Love of all the different kinds of diets, because they all get meshed together to meet the needs of the individual who was getting that particular delivery. And making that change, when you think about what that means for who you serve, how it gets paid for, because as we say, our clients pay nothing for their meals, but somebody pays for every meal, right? So how it gets paid for, what the actual program is, what technology you might need, all the different pieces, and what's your pitch, all those different pieces of the thing that you're trying to launch, the medically tailored meal intervention, is a very, very big deal. And so I would suggest that if you're interested in the accelerator, and we hope some of you are, that you start to think about the implications of that. Because the one thing I would add to, not only is it a big deal, it's also very exciting. It's really exciting to reach people who are sick, who are hungry, who otherwise really don't know how to take care of themselves. If you think back to the example David gave at the very beginning of his dear friend who had a really complex nutritional need that would be impossible for most people to figure out on their own, it's really rewarding to know that you are helping to save this person, to get this person on their feet if they can, but if not, at least to be as healthy as they can be, to manage their illness, manage their medication, not be hungry, and also be as healthy as they can be. So I would suggest, we're not trying to scare you away. We're just trying to say, if you're interested in being part of the accelerator, we would welcome your application, but we also want you to know that it is very much of a change, even though it feels like you're just adding on. So David, I don't know if you had any other closing thoughts?
Well, I was just going to get into the nitty gritty, which is classes start in July, and we typically start our recruitment campaign for applicants to the program, to the curriculum, in about January. So on the slide here are both Karen and my email addresses. If you have more specific questions unique to your program, shoot us an email. If you're interested in learning more about the accelerator or receiving the application, you can email us. You can also go on FIMIC's website, which again, from Karen, is
I'll just put it in the chat.
that's great, FIMcoalition.org. And there's an accelerator webpage there that covers some of what we covered today. But we're really excited about it. And as anti-hunger people, I think we're excited about it because it's a new revenue stream to address the issue that many of us have been dealing with for decades. But the idea of using food in a treatment regimen as opposed to a prevention or upstream regimen is very new, very exciting, and healthcare was not receptive to this, but I think within the last 4 or 5 years has become significantly receptive to this and are clamoring for more programs. So it's a great opportunity. We'd love to work with you. And I think we just have like 3 or 4 minutes. Does anybody have a question that they didn't put in the chat that they'd like answered today? You can unmute too if you want.
Right. If you just want to unmute and speak, that would be welcome.
All right. Well, I think, Karen, we have told the story and made the pitch. If we'd love to hear more from you offline. This presentation is both, you have access to the deck, and I know it's also being recorded. And so if there aren't any other questions, we'll let you go a couple of minutes early. But we are excited to engage with any of you that are interested in learning more about the field, even if it's from an advocacy perspective, shared advocacy perspective, and not the accelerator itself.
And we just want to thank you very much for your attention and for your interest. We really do believe very strongly in the medically tailored meal model, but to one of those questions that came up earlier, really do see it as part of the continuum of food as medicine, of which there are, it's the part that is the treatment part rather than the prevention part. And we're very excited to be partners with all of you in the Hunger Free Communities Network.
All right. Well, unless no one else has any questions, I'll just wrap this up with a couple of announcements. Once again, thank you so much to our speakers, David and Karen. We really appreciate your expertise that you've brought to us today. And so up next is a short 15-minute break, and then we'll begin the next set of our 4 workshops coming up, providing solutions and best practices and toolkits that you can utilize within your communities. To join one of these 4 sessions, you can just click over to the workshops area in the navigation bar to the left of your screen, and then make sure that you can see all 4 workshops being offered by clicking on the arrow so that you can scroll through all 4. So that concludes our workshop, and to exit this session, you can click on the red phone icon at the bottom of this screen and then click leave. Have a great rest of your day. Thank you very much.
Thank you, everybody.
Thank you
for hosting us.